Today I'd like to welcome Dr. Polina Zmijewski to the Brown Surgery Podcast. Paulina completed her undergraduate studies at Barnard College. She then went on to graduate school at Columbia School for Arts and Sciences, where she studied anthropology. She then attended the University of Tennessee, where she completed medical school. Paulina then joined us here at Brown for her general surgical training and will be heading to the University of Alabama, where she will be completing a research fellowship in endocrine surgery. So I'd like to welcome Dr. Zmijewski to the podcast today.
Good morning, glad to be here.
So Paulina, I think it's pretty fascinating, this project that you're doing within the department revolving around narrative surgery. I'd like to talk a little bit more about this today for the audience. So to frame this a little bit better, can you briefly explain what narrative medicine is and how you became interested in it?
So every PGY4 in our program is given this assignment to do a history of surgery grand rounds. And it's meant to sort of give us a sense for our history and allow us to take pride in that history. And I did mine on an unusual character named Anton Chekhov, who is a Russian novelist and short story writer, who was one of my favorite writers growing up. And in reading a lot of his short stories in preparation for this grand rounds, I began to realize the power of the narrative in sort of describing and giving a window into what a doctor's life is like. Not only does it allow people to get to know us, it lets us sort of get to know ourselves. And what I found most fascinating was looking at his writings in the late 1800s. His descriptions of burnout, especially in stories like Ward Number 6, were really pretty similar to things that we experience today. It seems like maybe the era has changed, but a lot of the bare facts of our profession and our lives haven't. So I became interested in medical literature, and I sort of encountered this book by Dr. Rita Charan of Columbia University called Narrative Medicine, Honoring the Stories of Illness. And in this book, she actually took the idea of narration, so interacting with the humanities and interacting with pieces of literature and responding to them through like intentional reflection, and she made it into a pedagogical discipline. She figured out a way to create a curriculum around how to teach doctors to read and to write, and through that, how to use skills of reading and writing and listening and speaking to become better clinicians. That's narrative medicine, but I think problematically, surgery is a little bit different, and we know that it's different. What we do is different. The traumas we experience, the kind of cognitive dissonance that we have to employ to do our jobs well, it's something that's very unique to surgeons. A lot of times I think that our requirements for clear, quick, and effective thinking in moments of crisis, the mortal cost of our mistakes, the personal cost and danger associated with practice is really closer to something like narratives of war. And so a lot of times doctors from surgical specialties have a difficult time relating to curriculums written for medical specialties. So what I did is I took the concepts outlined by Dr. Charan in her book, and I sort of made them more accessible to our training paradigm and our training environment. And I tried to create a way to make these projects work within our workflow and our daily practice. Essentially what I did was I created a curriculum that involved weekly or bi-monthly prompts that included a piece of art or literature or music for the residents to review, and then sort of a series of questions for them to respond. And they can either respond in writing, they can respond within reflection with each other, or discussions with faculty or among themselves. And then these prompts were complemented by a group discussion of the pieces every few months. So we did a two-hour didactic sessions where we discussed 3 pieces of literature each with a number of facilitators, one from each PGY class.
How was the overall response to these prompts?
I would say that primarily the responses were more verbal than they were written. I think I received a lot more responses from residents who wanted to sort of talk about a lot of the concepts either with me or amongst themselves in addition to faculty. But I think what the value of the exercise was is that it got people sort of thinking about what we do in a much more intentional way.
I think when I was doing some background research into this podcast, I came across what Rita Charan said, and she bases her narrative medicine on attention, representation, and affiliation. Can you explain these concepts a little bit more to the audience?
So these are something that Dr. Charan calls like the 3 pillars of narrative practice. To quote her directly, she says, "Attention connotes the emptying of the self so as to become an instrument for the receiving of meaning of another." So attention means to give someone the gift of listening. So it's about opening yourself and receiving what's offered. It's about listening without bearing judgment. And I think that that's something that's really important for surgeons to learn to do. We have such an intense urgency of time in every moment of our day that it's very difficult to learn how to slow down, how to listen to somebody, and how to really hear what they're trying to say to you. So once you accept what's offered, the second part of the curriculum or the second part of narrative practice is to reflect or represent. You internalize that experience that's been expressed to you and you make it into something. So either through a work of art or through writing, you internalize and reinterpret what's been given to you to make it meaningful to you. And the purpose of these two activities is to culminate in contact between two individuals, whether it's a doctor to a doctor, a surgeon to a patient, or even a surgeon to themselves. And that contact or that affiliation is sort of the purpose of narrative practice. It's to humanize a discipline that has historically been very dehumanizing.
So essentially what I'm hearing, this could be like a form of therapy, or this could be a therapeutic process for individuals.
So it is, I think, to some degree a therapeutic process, but I think the important thing to understand is that it's not just therapy. So it's not meant to be like a group of people griping. It's meant really in a very intentional way to teach. So it's a learning exercise. It's about learning a new way to communicate. And I think that that learning is a critical portion of why the curriculum is so important.
Do you think that focus on learning to communicate is missing in general surgery? Is that one of your jump-offs for introducing this topic?
So part of it is about communication, but to some degree, it's about the change of a culture. So I think that the value of narrative surgery and narrative medicine is its ability to transform culture. I think the reality is that our field is changing. Our culture of training hasn't changed in many, many years, but our field is changing. There's different demands placed on us than were placed on surgeons of previous generations. And I think that narrative training allows us to free ourselves from a number of cultural constructs which are designed and tailored to favor and train a particular phenotype of surgeon.
Can you expand on these cultural constructs a little bit more?
So, yes. One of the constructs that I think narrative training can help move us away from is this sort of construct of competition over collaboration. So I would argue that in order to thrive in our modern training environment, surgeons have to learn to value the success of a group over successes as an individual. Through the discussion of works of literature, we can learn that our experiences, regardless of our training level, are similar or the same. And we can learn to collaborate and explore common themes in our lived experience. These sorts of collaborative processes, these sorts of discussions can help people prioritize collaborative success. The ability to discuss works of literature helps us transcend hierarchical barriers. Perhaps not every single person in the room, the intern or the junior resident, is an expert on the complications of a Billroth 2 procedure. And in that particular instance, it's important to defer to expertise. But it's also important to learn how to learn from each other. And I think that we can all be experts on our relationship with a work of literature. So it's a way to break down hierarchical barriers and allow people to speak to each other.
I think that's an important part of this whole narrative surgery has been the inclusion of literature in your prompts, which we'll talk a little bit more in a few minutes about. But what inspired you to add that twist to narrative medicine / narrative surgery? Because I think that's been really inspiring to the residents and faculty who've read your prompts.
So I've been a reader my whole life. I read really voraciously and really widely. And I think it's been one of the most enriching experiences of my life is to be able to live through the eyes of somebody else. And I think it has, in my own development as a person, helped me understand people and empathize with people. Surgery in and of itself is a very dogmatic discipline, and our texts are written by a very specific phenotype. I think that the wonderful thing about being able to insert literature as part of training and as part of curricula is that it inserts the voices of other types of people, of women, of people of color, who are oftentimes excluded from our primary texts. It also allows us to deviate from the standard models of success and allows us to believe that there's other ways to be successful as a surgeon besides the models that have previously appeared before us.
I guess what I want to know too is, like, when you send out these prompts, do you think about the literature first or the literary work that you want to cite first? Or does that come to you when you're thinking about what you want your readers or the folks that you're sending these prompts out to get inspired by? Like, what prompts the prompt?
So I guess there's an old anecdote Degas, like the French painter, had a neighbor who was a poet, and he said, "Poems are not made of ideas, they are made of words." So for me, I think the literature comes first. So I read something and I sort of think about it. And literature has a way of sort of, I don't know, burrowing inside you and blossoming there. So I usually read a piece and I find something in it that we sort of can relate to in a clinical context, and I build the prompts around that.
Earlier it's when we talked about Rita Sharon, and you mentioned that narrative prompts are for either written, verbal, or internal reflection. Why did you decide to focus on the writing piece of narrative medicine or narrative surgery this year with residents and faculty? I mean, do you consider reflective writing to be more explorative and or therapeutic?
I think that the writing piece didn't work out really as well as I thought with this group this year. I think that in order for surgical residents to really have motivation to write, it needs to be sort of built into their curriculum or built into their day. So I sort of chose to build the curriculum as a little bit more free. I didn't assign homework. I didn't make anything mandatory. I wanted people to participate in it if they were interested and not participate if they were not, because our time is very limited. But I do think that the reflection is an important part of it. And I think that some of the responses I've gotten back from residents and faculty have been extraordinary.
Do you think narrative surgery should be a standard part of, I don't want to say curriculum, but part of our culture here going forward? And how easy would it be for other programs to potentially adopt this?
So I think there's a number of things about narrative surgery that are incredibly important. And I think that it does help us sort of overcome a lot of what I think the barriers are to what I think is kind of standing in the way of our success as growing as a discipline. So I think that narrative surgery provides the elevation and the elicitation of voices that we would not generally hear from in the field of surgery. It allows us to transcend hierarchical barriers by allowing us to speak to each other about something in which every person can have expertise. It introduces the idea that there are multiple truths, because I think that as a discipline, we have a problem with tolerating ambiguity. And I think we have a problem with understanding that we will not always be able to reach consensus, that we will not always be able to come up with an answer, and that sometimes that needs to be okay. And some of the most complex and most interesting pursuits in life don't have correct answers. I think another important thing about narrative surgery is that it sort of frees us from another concept which I find crippling within our discipline, and that's urgency over time. We're very hurried. We work fast. We're required to think fast. We're trained from our very first steps into surgical residency that it's better to just make a decision and make it as quickly as possible and follow through on that decision than it is to waver, to flip-flop, to waffle. And I think that that works in some contexts. So that's a very adaptive behavior when you have minutes to save someone's life. But it's a very maladaptive behavior when you're talking to patients, when you're discussing treatment options with colleagues, when you're going about building a surgeon that's a whole person and a practitioner that treats the whole patient. So I think that the ability to sort of wander, to sort of grow together, to discuss a piece of literature in a way that's not hurried, in a time where your speech doesn't have to be precise and limited, helps us sort of overcome that obsession with urgency over time. And additionally, it helps us value something that I think we're not really taught to value enough in the medical field, which is qualitative research. So the quality of something rather than our worship of data and numbers. Because even if data and numbers and statistics are incredibly adaptive and useful in the context of deciding, for example, whether to drain or not drain someone after a Whipple, qualitative data has a place and an importance too. And I think that narrative disciplines elevate qualitative data. I think that all of these things are very valuable towards training a well-rounded surgeon, and a surgeon that can respond to the demands placed on surgeons today. A surgeon no longer dominates the room. It's never a one-man show anymore. There's plenty of collaborators. There's other people in the room that need to have a voice. There's actually been shown in a lot of studies that in strictly hierarchical structures, systems tend to perform worse. And I think that narrative training is a way to help us sort of overcome a lot of those barriers to really succeed and collaborate as a group and learn how to grow together as a group. I think it can be very easily inserted into a curriculum as long as it's prioritized. So in giving it as much notice and as much thought as you would educating a surgeon as to how to perform a Roux-en-Y, I think equal amounts of time and effort should be dedicated towards learning how to listen and to speak.
Yeah, I think that's important. I think carving out time is probably something that's valuable and also difficult to do, especially for a surgical resident, because their hours are so much accounted for in their work week, but allowing them to sort of step away from that clinical practice and giving them time and space to reflect on practice or reflect on a prompt that's been sent out, such as the one that you sent out, I think is equally important. And I think there's educational value in that as well.
Yeah, I agree.
Before we close, would you mind reading a prompt, an example of a prompt that you send out monthly to residents and faculty through the year? Because I think it would give a better sense to the listeners as to how you set them up.
Sure, I can absolutely do that. So this is one that I sent out a couple of weeks ago. So it starts, "My dear colleagues, a couple of weeks ago I was in the OR in the early hours of the morning sewing in a kidney, and I started thinking about all the things that my patient would never know. The recipient, for example, would never know that throughout the case, my knees were gnawing. My neck hurt. I was exhausted. I started thinking then about all the things I would never know about this unconscious person in front of me. We were hard at work, doling out 20 more years like sugar rations, and I'd never know what this patient would do with them. Surgery sometimes feels like an anonymous love letter, a gift with no return address. The unique experience of surgery lies in our existence on the periphery of the biggest moments of our patients' lives. We witness their grief, their suffering, and their loss. While we can guide our patients through these experiences and give them a tender and empathetic ear, we experience grief and joy in a widely elliptical orbit around their lived experience. Especially as residents, more often than not, we are faceless, nameless guests in a very serious room. It's easy to forget, but deeply important to remember the privilege of being there at all." So now I provide them with the literature piece that I want them to read for the week. So I say, "Sadiq Zukogi is a deeply lyrical poet with a new book just released called Your Crib, My Qibla, about his experience of grief losing his young daughter. I've included one of his poems, The Quenching, which dissects so precisely the way that grief burrows in the bones, the way that loss has a way of resting deep inside you." So here's the poem, The Quenching. "It is to be hoped that a tree will let its leaves rot into earth as nourishment. I am searching for the name of my daughter, a piece of ribbon I found hanging on the door hinge. I stare long until I hear her voice rising from the knotted edges of the silk, and I enter into a conversation like a racehorse released into fire. The ribbon stuffed with all her words, frothing like a burning piece of a butterfly's wing, greeted with water baubles, I mean it in contrast of the disrobing silence of quenching. The redwood flower unwilts into a new fragrance, a smell like the moon common to every night that visits, clatters along all the crannies of an unforgettable half-side of a dark day widening into newer edges. The willow that falls into the ears of God, a thrush housing its body inside its own wet wings. Do you not see, child? Once your songs endure inside my bones, they will consume the loneliness, yours and mine." And at this point, I usually provide the writing prompt for the week. So in this email, I said, "I think that our grief rests in our bones too, but differently. We remember the grief of the patients we encounter. We peer in and carry with us what we are able to see. This week, write about your life on the margins. Write about a grief or joy you've experienced in practice that did not belong to you. Write about a patient whose songs endure."
That's awesome, Paulina. I think, these quotes and the literary works that you insert into your prompts are really inspirational, and they allow residents and faculty to kind of get into the moment and encourage the writing process or the reflective process. How has it been welcomed this year in your experience? Like you mentioned too that there's been verbal response to it. What would you say in terms of narrative surgery as a success here? How would you gauge it?
So I came into it without really a lot of expectation. I hoped that people would write responses to the prompts, but I think I was more interested in sort of prompting discussion and sort of opening up a door for discussion that really hadn't been opened before. So I definitely have received some written responses to the prompts that I put out by faculty and residents, and those responses have been really remarkable. But I do think that the value is really in the discussion sessions and in the sort of weekly reminders to sort of be more mindful about our daily practice. So I think in that way it was successful.
Yeah, and I want to add too, I had the opportunity to be involved in one of the sessions where you did this as part of our education curriculum, and the engagement from residents and some faculty alike. It was great to see, because I think speaking in a group about some of these topics, it inspired others who might not necessarily wanted to speak up about the topic to ultimately speak up when they heard their colleagues expressing the same either frustrations or experiences that they too experienced, but might not have spoke up otherwise if they were in a different circle or a different conference or a different setting.
I think there's definitely interest. I think it's just about creating the space for it.
So why do you think that narrative training is critical for our profession, or for surgery in particular?
So I think narrative training is critical for our profession because our trainees are frankly at uniquely high risk for burnout, post-traumatic stress, and dissociative behavior as a direct result of the work that we perform. So this has been borne out in qualitative and quantitative data kind of across the map. And narrative training imparts critical listening skills, as well as psychological and affective insight to trainees. It gives residents a language and a forum to discuss difficult topics, and it helps them work through behaviors that are adaptive in the operating room, but sort of maladaptive out in the world. It can serve to develop stronger mentoring relationships between faculty and residents of different levels through narrative affiliation, which is particularly important in our strictly hierarchical discipline. And I would say, in short, the potential of narrative training lies in a quote that I read from Franz Kafka a lot of years ago, which is that a book can be the axe for the frozen sea within us.
Awesome. Well, I appreciate you taking the time to sit down with us today. I think not everyone who listens to this is going to be familiar with narrative medicine or narrative surgery, or our attempts here at Brown to get this going as I don't want to say a curriculum, but part of this. You as the wellness chief here this year have really done a great job rolling this out and setting the stage. And as you graduate and pass the baton to the next wellness chief, what would you say to them to enable them to be able to continue this curriculum?
I think what's important in any sort of leadership role is to look to the needs of the people that you're serving. So look at it as a position of service and try to see what the need is and how you can best fill it.
Well, thank you again for joining us on the podcast, Polina.
All right. Thank you for having me on.
Thanks, Polina. For those of you who didn't know, Dr. Zmijewski is also a published poet and essayist. She is a former student of Guggenheim Fellow and multiple Pushcart Prize winner Dr. Richard Jackson, with whom she has taught and read poetry internationally. She has been published under a pseudonym in the last month in Oddball magazine and the Intimate Journal, and her essay Field Notes on Frame is forthcoming in JAMA Arts and Humanities. She was recently awarded Poet of the Month on Indie Poetry Please, presented by Orna Ross, ranked by The Bookseller, the UK publishing trade magazine, as one of the top 100 most influential people in publishing. Dr. Zmijewski's first book, Brilliant Day, Deserted House, is slated for publication in March 2022. I'd like to thank Dr. Zmijewski for joining me today for the first in our series of Chief Resident Podcast projects. Stay tuned next week, where we will continue our Chief Podcast series with Dr. Zambarinis on HIPEC management. In future episodes, we will also be covering esophageal perforation, crush injury and compartment syndrome, and carotid disease, to name a few. So stay tuned for those, and I'm looking forward to having you back with us in the next episode.